We're going to start off with the title, which is long and windy, because it is after lunch, I thought. What does a diagnosis of CLL actually mean for patients? Well, that's bloody presumptive, isn't it? He's a doctor. He's not a patient. What the hell does he know? So I don't know, and that's what you're going to answer today for us, between yourselves. Together, it's going to be a mutual effort. And what are the essential steps for patients to take? And we're going to talk about all that as well. And you're going to contribute. So if you thought this is going to be a soporific put your bloody feet up, you're in the wrong room. I'm sorry about that. There's a bar next door. I don't think the CLSA have opened the tab yet, have they, for the bar? Waiting for my credit card. Yeah, when the wife gives it to me, I'll share it with you. So just so we get a feel, to get you going, think about that drink, get your arms going. Feel for the audience. Who's actually a patient? So maybe who's actually a carer or a partner of a patient? Who's a partner who doesn't care? You'd rather be bloody shopping, wouldn't you? Yeah, I know. Who remembers the day they were diagnosed? Who doesn't remember? So of those patients who've not received treatment on watch and wait, you all remember, don't you? Exactly. That thing alone tells you something enormous has happened in your lives. You've forgotten your kid's birthday. Some people have forgotten their kids' births, especially the blokes. Well, you weren't there for kick-off, so it's hard to remember. And you probably weren't the dad anyway, so probably as well you weren't there. That's why she asked you to wait in the waiting room. She wanted to see what it looked like when it came out. Before saying, meet your dad. Or not, as the case may be. You all remember. I don't remember every time I've told a patient they've got CLL. So your experience of receiving it, and my experience of giving it, is not the same in impact. For you, it's life-changing, or can be life-changing. And what we're going to discuss today is how to try and stop it being life-changing. Sometimes it's life-enhancing. You're drifting through life, you're being abused by your children, doing the childcare for them. Instead you think, well, sod the kids, I'm going to look after myself and put myself first for once. Wait a minute, I'm not leaving all my money to my kids, I'm going to enjoy myself. I may be on limited time, stuff then. It can be positive, but of course for the overwhelming majority of patients it's not. And we're going to explore that today with your help. Because I say, I'm not doing all the work. I'm not a patient, you're the patient, you know. So the first consultation and the second consultation, in my experience, is the most pivotal part of the whole experience. What are you told and what does it mean to you? If those two do not go well, it's very hard to pick it up later and carry on and get the right information. So a lot of people are coping with a bad or first experience, or less successful or less helpful experience of it. And of course, 2/3 of you didn't know you were ill. You had a blood test for another reason. You know, it's a disease of the more mature or more experienced in life. 2/3 are found by chance with a blood test for your prostate trouble, your hip trouble, your gallbladder trouble, something else. So the first reaction when someone says you've got leukemia, well, that can't be right. I was out on the razzle yesterday. And then you think, they're going to bring me into hospital. They say, oh, don't worry about it, I'll see you in 3 months. What bloody sort of leukemia is it? Well, you get turfed out the door. Oh, I know what sort it is. It's the sort for which there's no treatment and there's no cure. So there's no point in wasting time talking to me because there's nothing they can do. All these things I've heard from patients about that very first experience. So 2/3, they don't even know they're ill. 1/3 do have symptoms, but they tend to be very non-specific. Tiredness, weight loss, few sweats, more prone to infections. We'll touch on infections later. Occasionally you notice lymph nodes on you. And that usually makes patients think that I may not be right. All these other symptoms, people aren't thinking cancer necessarily. They're thinking hard work, life, loveless marriage. That's why I feel fed up in life. There's all sorts of reasons. You don't think, and you go in there and somebody says, oh, by the way, and then you hear the second word, chronic. Oh, thanks a bunch. Incurable, no treatment, miserable life, pain. Most people think pain, the commonest word that follows chronic is pain. So you get two, hit between the eyes with two things, the word leukemia and the word chronic. The word lymphocytic means nothing. So, again, who'd ever heard of CLL before you were diagnosed? Maybe about a quarter of you. So that's good in a way, because in the old days, no one used to hear about it, because often we never told patients they had it. Because you didn't need to. It's a need-to-know basis. The doctor knows best. But in CLL, as we're going to discover, doctors don't know best necessarily. So basically, what was the first reaction? Shock? Disbelief? I've never heard of it. That can't be true. And as you go through what patients have actually exhibited to me is fear. What the hell does this mean? I walked in here fine. And you're telling me I'm not going to get back to the car in the car park. Well, at the Heath, we say thank God for that, because it was so expensive. Paying for the car didn't bother me anymore. And that word leukemia, that word chronic, people have fear, have concern. What about my family? What about me? What about the job? What about our financial situation? Anger. Why didn't the GP tell me? Why have I got this?
Sorry, can we just move your mic to the side a little bit?
Steady on now, steady on. I'm not being paid, so I'm not sure why you're listening. And what affects a lot of patients is loss of control of their lives. Everybody, every adult, has certain things mapped out in your life, certain things you're going to do. Next week I'm doing this, next month I'm doing that. I'm booking a holiday. It's my granddaughter's wedding. We all have things in our mind, goals we want to achieve, which is what keeps us going from the miserable bloody times, or miserable weather, because don't worry, it's my granddaughter's wedding in April. We have those things. And somebody comes along and trashes it all and says, by the way, you've got leukemia. And it's chronic. And you're meant to go out the room. What the hell? What the hell's just gone on in there? And that's why that first and second appointment, the first time they knock you down, by the end of the second time, you're meant to be built up again to move forward with your illness. But that often doesn't happen. And if you've been in NHS clinics, they're usually busy. It's not the most personable of places in some places. It's just the volume of work. And you've got CLL, you don't need treatment, you only need 2 minutes. And unfortunately, that's a bit of the mindset. Money is a big worry for anyone. Rarely people say, well, that's fine, yeah, I hear what you say. So what does that mean, doc? And he automatically exhibit that thirst for knowledge. But most people, that comes a bit later. So hands up if you went through any one of those experiences or those feelings when you were told. Yeah, maybe 2/3. So what does that actually mean in reality? Well, the Kluber-Ross model is there's 5 stages to grief. Some people have modified that to 7 stages of grief. And grief in this meant, you've lost a child, you've lost a loved one. Shock and denial is there. Wait a minute, we got that with our CLL when they told us. Pain and guilt is one of 7. Don't tend to get that with CLL. Anger and bargaining, that's exactly what you get with CLL. Depression, reflection and loneliness. Eventually, with grief, where you lost a loved one, our cat died last week, it was not a good time for us. You get through things and you find a way out the other side, you use that information and you come out the other side. And eventually you get to acceptance and hope. So what you're getting through those two first consultations is actually going for a bit of a grief reaction, but you don't know it. And you may actually be very, very well because you've been found by chance. But the emotion and reaction is just the same that you're going through, and you go home. And as we now know, there's a lot to work on post-traumatic stress disorder or syndrome from those returning from the battlefield. That's what put all the money into that research. But it's very well described now that cancer patients can go through that same experience. People with near-life death experience, car crashes, women abused by their partners, can also get PTSD. Your white count's okay, nothing's changing, I'll see you in 3 months is what you get. When in fact, what you've just experienced is something much more than actually you've been told you've got an illness. It's not you need your gallbladder out and I'll remove your gallbladder in 3 months, 6 months if you're on the waiting list in Wales, and then the problem is gone. And most of this has to occur outside the consultation room with the doctor. Did anyone not have that sort of experience? There's a few. Only one of them's my patient. Yeah. I'll be having a word with the rest of you later. So that's the starting point. And then someone says, you may or may not need treatment, and you may or may not live a long time. Well, that's really bloody helpful, isn't it? Yeah. Thanks a bunch. What it's all about is information. To take control of your illness, to take ownership of your illness, to stop feeling as if you're a victim. You've got to take ownership. This bloody disease has got me. What have I ever done? Yeah, I went to church every Sunday. Doesn't count for much. You can still get CLL. So a lot of it is access to knowledge. The trouble with the knowledge, the written knowledge, is a lot of it is out of date. So you need up-to-date knowledge, which is why the CLSA, Leukemia Care and other groups, absolutely fabulous, giving the data up to date. Because if you look at our website, some of it is factually incorrect and less than helpful, dare I say. But of course, you think your source of information is your doctor. So how many new CLL patients will your average GP see a year? They'll see about 1 new patient every 5 years. Remember, they're seeing about 20 patients a day, so just do the maths. It's not surprising they can't switch on into CLL mode. It's easy for people like me, because really, I don't do anything else. CLL pub, go home. That's CLL pub, go home. So, yeah. And some of the information can be quite sensational, depending on where it's come from. I've read things and thought, bloody hell, I didn't know that, but then it's not true. It's often not well balanced, depending on where it comes from. And dare I say, patient forms can be a mixed blessing of what people's experiences are. Are they truly representative, or are they just being particularly unlucky with it? Your wonderful children will be on the internet, God bless them, reading everything. And then coming up with these ideas. What did the doctor say about this? And what did the doctor say about, you can't eat that, you can't do that, you've got leukemia, you know. It's less than helpful, a lot of it. And of course, a lot of it isn't relevant to you. The Leukemia Care, the Bloodwise book talks about radiotherapy in CLL. I think I've given 1 patient radiotherapy in 15 years. It's a nice little section on it. It's been there since the late 70s. So not all of it is relevant to you, but when you read that, you don't know what's relevant to you and what isn't relevant to you. It's about you, not about it, as in the disease. And of course, you've had to face, having come out with the news, what actually do you say to people? What do you say to your partner? And vice versa. The partner is partly going through a similar experience to you, to a greater or lesser extent. So there we are, we come out the room, I've got CLL. My loving partner turns to me and says, how do you feel? And I say, I feel fine. She says, you lying bastard, you look awful. Well, I looked awful before I went in and got the diagnosis, and we didn't even know I had. A lot of people think cancer and illness brings you together. Quite often it doesn't. It actually reinforces, if not exaggerates, existing pressures. Because everyone's worried. You're worried in different ways. But what you tell the loved ones is very different. What do you tell the children? Especially if you're on watching weight, you don't want to worry your children. You've always been their carer, not your carer. What do you tell them? Nothing may happen, but something may happen. So what actually do you tell the children? Would you not tell them at all? Maybe I shouldn't do this, but I'm fed up talking, I need a rest. Hands up if you've not told your children. Yeah, I'm surprised it's only one, because an awful lot of patients don't. Oh, two. Sorry, three. Oh, they're coming out now. Now someone's been brave enough. 4. Okay. And the rest you haven't got kids. Yeah, fair enough. You're trying to save their feelings. Most children get very angry when they eventually find out about it. It's if you don't trust them to share your secret with them. But everyone is different with it. Whether you tell them, well, there's no right or wrong answer. You've got to decide what's right for you and your family. What do you tell work? Do you tell them I've got leukemia, therefore I'm going on 6 months sick? Or do you tell them there's nothing wrong with me, I can still do this job and I'll be stuffed if that little shite in the office is getting my job? What do you tell? Both. What do you tell work? If you're loving work, you want to carry on. It's part of you as work. If you're one of those people, the last thing you want to do is give work reasons for doubt your performance, doubt you as a person, and doubt that you're capable of doing the job. You're living with all this yourself. And of course, the real dirty little secret is what do you tell your holiday insurer? Yeah, there's some dishonest people in here, aren't there? I'll say just one thing about insurance. If you've got watch and wait, you're probably perfectly well. You go abroad, you trip over the curb, you break your leg, you go into hospital, somebody does a blood count, it's bloody obvious you've got CLL. Ah, says the insurer. So you lied about that, did you? Maybe you lied that you limped as well, and that's why you fell over the curb. So even though what you're going with is almost certainly nothing to do with CLL, if you're watching weight, these characters, they're not charities. They're not going to pay out if they think you've not told them the truth. Most insurers, watch and wait, never had treatment, they ignore it. But more and more we're seeing they're just pushing the price up because they can. Hands up if you think all insurers are bastards. Oh, you've already got your hand up, sir. It is very difficult, and every insurer is different. They are money-making businesses. Those who are really enlightened know it's irrelevant. Even those who know it's irrelevant may still try and charge you. But do shop around. And some insurers which were good last year are not good this year. Then the next year they may be better again. They don't really understand CLL. It's the truth of the matter. They know you want to go on holiday. They know you've already spent probably a fair whack of money going, and therefore they can sting you for a little bit more. Yeah, have a good holiday. Wonderful folk. Are they hell? I didn't count the number of hands when we mentioned about what do you think of insurers. But they're not charities at the end of the day. So what does that actually mean for patients' CLL? Back to this thing of, even if you've got stage A CLL, you're probably thinking about your disease, if not every day, every other day. It's especially true in America, because you can't get life insurance, you can't get a mortgage, you can't get a car loan if you've got stage A0, watch and wait CLL. You really are in a difficult situation. So hands up. We'll do those who haven't had treatment. So we'll do the watch and wait. Hands up if you think about your illness once a week. Yeah, the overmajority. The overmajority. And if you have had treatment, how many think about it once a week? That's very interesting, isn't it? And that's a very interesting thing we see. Some patients, at least when I get to treatment, at last someone's doing something for me. They actually almost get a relief reaction. But that's just bloody daft. You only need treatment if you've progressed. But a lot of patients are living with this feeling of something's about to happen. At last, somebody's listened, I'm having treatment. But that's really a failure of that early process of understanding, coming to terms with your illness without treatment. People live with this. And what this shows here, emotional QOL, that's quality of life, overall quality of life, and your fatigue score. If you keep thinking about your illness, your quality of life is significantly lower. So how can you try and forget about your illness? It's phenomenally difficult. So again, I'm going to have a rest. What do people in the audience do when they're thinking, actually, I'm fed up of this shadow, this cloud follow me around, and one of these days it's going to piddle on me, but I don't know whether that's tomorrow or 20 years' time. What coping strategies, to use that horrible term, have people used? Lots of holidays, denial, I like that. No. Well, in some ways, getting fitter, getting healthier, eating a better diet, doing more exercise, is all part of that. This ain't going to beat me. I can make myself better by doing things better than I did before. Those are part of coming to terms with this and something positive coming out of the situation. Any other coping strategies?
Yes, when I was working in a factory, I told them I had CLL, and about 2 o'clock I used to say, I'm feeling very tired, I'm going in the nurse's room, I'm going to have a kick for an hour.
Yeah.
And that worked very well. For a number of years.
And the nurse wasn't in the bed by the time. Too tired, yeah. Yeah.
Too many different ones.
Too many different nurses. Bloody hell. You're going to be popular after this. Over there, the lady.
I listen to audiobooks and podcasts a lot, got me thinking. And also go running as well, but yeah, lots of listening to things.
So what happens in reality is you've been given something that no one wants to hear, and you virtually had to work out how to manage it yourself. And as I say, if you need chemotherapy, you're back to the hospital all the time, and you're getting help and advice around, mostly around chemotherapy, rather than we're living with CLL. Getting through the chemotherapy or whatever is the most important thing. So ironically, those patients who automatically become part of the hospital do get, in a sense, more input and a better service, albeit if those ones who are at home on their own, who are really the ones who are struggling with living with this disease. So try and cheer yourself up. Try not to think about it, because your quality of life will go up. Something positive comes out of something negative. Tiredness is probably the biggest problem I have as a clinician, because somewhere between 70 and 90% of patients complain of tiredness. And cancer causes tiredness. And we've heard all this before. Tiredness and CLL only really appeared in the textbooks in the last 10, 15 years is a symptom, because everyone with cancer gets tiredness. The thing is, when you look at CLL, the average age of patients diagnosed is 72. On average, they've got 4 other medical conditions already. By the time you're 72, other bits of you are falling apart. Heart disease, previous cancers, cardiac conditions, diabetes, hypertension, rheumatoid, da-di-da-di-da. So is the tiredness due to CLL? Or is your tiredness due to one of these other things? Or is your tiredness, not on here, due to depression? That makes people tired. And of course, you go, and I feel tired, doctor. And you say, well, of course, that's CLL for you. Oh, So I've just got to live with it, have I? Well, that's CLL, and you don't need treatment because you don't qualify for treatment according to our criteria for needing treatment. It's the most difficult thing, is tiredness. So the first thing with tiredness, is it your CLL? There is no test to prove it. What you ought to do is work for those other things to rule them out. Am I eating unhealthy? Am I overweight? Are these other medical conditions being managed adequately? Is my GP, my blood pressure too high? Is it the medication I'm on for these things? Is it the bloody beta blockers that's actually making me tired? Because at the end of the day, it may be your CLL, but there's no test to prove that. And it's very easy to say, it's your CLL, that's what we expect. Sorry, you'll just have to get on with it. Positive action. Make sure it's nothing else. And then if it is tiredness, back to the lady books and everything, the tiredness ain't going to go away, but you can distract yourself from feeling tired. Every time EastEnders music comes on, I just wilt at the legs. Thank God for the remote control. I can't switch it over early enough. You think survival in cancer's bad, you should live in EastEnders or Emmerdale. I mean, these are dangerous parts of the world, aren't they? Survival there is really not good. Distraction, being active and busy, is an enormous help to patients. But you've got to find what works for you. I mean, who jogs? Thank God for that. I absolutely hate jogging. I mean, your knees aches, you breathe in the car fumes, you cough your guts up at the end, you say, that's really good. I feel so much better. I trained in Newcastle, I lived in Felling. For those who don't know, the Felling bypass where the Gateshead Stadium was, when Brendan Foster was in his pomp. And you're expected to run. You know, why do you live in Gateshead if you don't run? It was bloody awful. It's where the Great North Run runs past now. It was absolutely horrific. And you're telling me this is doing me good? Sod that. Find something that makes you feel good. Whatever it is. It could be painting. It could be gardening. It could be pulling the legs off bloody spider. I don't know. Anything that makes you... I can see the letters of complaints now already. Positive action for this, because there's nothing your doctor can give you to make it better. Food supplements, vitamin supplements, if they make you feel better, by all means speak to your doctor. We don't want you taking too many of them. Some of them can interact. If they make you feel better about yourself, who cares if there's any evidence out there in the literature that makes you feel better? If it makes you feel better and it doesn't cost you a fortune, number two, because there's cowboy companies all over the bloody place. Yeah. Let me. Who takes supplements? Who takes supplements? Hands up higher. We're going to do a little test. Keep your hand up. No, keep your hand up. I know you're tired, but keep your hand up. Who pays more than £10 a week for them? I forgot this is Wales. Yeah, we don't believe. Our idea of a healthy diet is half a packet of chips, isn't it? It's half and half. You know, it's not all chips. I have rice with it. Yeah. Do not spend a fortune on these supplements. And it's very simple why. If we had cheap things like vitamins that made patients markedly better, you as a taxpayer would be going nuts, because I'm handing out treatments at £30,000 per patient per year. Why am I spending money like that as a doctor if I could give you a few gummy vitamin sweets and make you better for £10? If they work for you, great, but do not spend a fortune. If you are spending a fortune because you're too embarrassed to put your hand up, try and find a cheaper alternative. But don't use the word cheap. You know, find yourself a bargain. They do work. They help enormously for patients, but there's not a lot of evidence that they are essential. If they work for you, absolutely brilliant. Then you hear the word staging. There's various staging systems. We know about CLL, lymph nodes, hemoglobin, white count. Am I stage A, stage B, stage C? That was the first prognostic marker. How advanced was your CLL? And does that make a difference whether you've got one lump, two lump, or no lumps? And this got refined later, it's better slide. So if you're stage A, you're probably going to do better than stage B and stage C, and the same with the RI system in America. Bin A, not Binet, Bin A, French. We tend to use the European version in the UK, at least we do for now, until Trump insists we use the RI system when we do a deal with them. We use the Bin A. You tend to. It was the first prognostic marker, the first thing that said that these patients may not be the same. And we've turned into a whole industry since then. But let's take one step back. How many people know cancers where you've got a cancer and the doctor tells you to go away? Usually with cancer, the instinct is the earlier you get it and the earlier you treat it, the better you do. That's just logical, isn't it? You don't let breast lumps say, well, actually, you've probably got breast cancer, we'll just let it get that little bit bigger before we think about doing something. It's absolutely illogical. And in fact, the data goes back to these two papers in 1998. Who remembers 1998? Yeah, you've probably been at Butlins at Minehead, haven't you? Music of the 90s weekend. Yeah. That basically, back then, we did a study in Britain and in France. Those people watching wait, early stage disease, we call them, half of them will get chlorambucil and half of them won't. And there was no difference. But there wouldn't be, would there? Because chlorambucil had a great treatment. So you're having nothing or you're having a little bit of something. And all this thing of watch and wait still goes back to that data. 21 years old. Maybe we should have had a party. 21 years of watch and wait. There's no evidence treating earlier makes any difference, but then it wouldn't, because the treatment wasn't any good. You're really getting watch and wait versus watch and wait plus. So no difference. And that is still the dogma. So we need those studies where with the newer agents, more effective agents, whether watch and wait is still correct or not. Because back to watch and wait, these are still patients who are very tired, who are still living with something which is affecting their lives. No one's saying you don't need anything. What they're saying is no evidence chlorambucil, in particular, does you any good. Although this is chlorambucil, the French, if you don't succeed with one drug, you give 3. They gave a thing called COP, cyclophosphamide, vincristine, prednisolone. It's no better either. Because chlorambucil wasn't effective, let's give more intensive therapy. Go there. It made no difference in reality. So that's why there's watch and wait came around, or you probably know watch and worry, because what the hell's going to happen? So I'm taking these prognostic markers. This is clinical stage A, B, C on the left, showing you what happened in terms of survival. Rise on the right, a bit more messy. We're a bit simple in Europe. We like our lines wide apart, not these Americans, a bit sophisticated. They can deal with little lines close together. And then on came other tests, lymphocyte doubling time, beta-2 microglobulin, cytogenetics, CD38, prognostic markers. Hands up if you got good prognostic markers. Hands up if you got bad. Hands up if you haven't got a clue. Yeah. If you take these things, when you actually look at the data, they're 70% accurate. So that means if you took 100 patients, CD38 positive will identify, will tell you of those 100, 70 would do bad. What they don't tell you is which 70. Because you have a high CD38, but actually you're going to do well. You have a low CD38, but actually your disease is going to wake up. So they're only 70% accurate. Tossing a coin, heads or tails, is 50%. So it's marginally better. So who would sell your house if you had a 30% chance of not getting your money? No one bases their decisions in life on a 70% chance. But that's prognostic markers and what it does. And that's why when they all come out, and there's somebody published over 20 papers in prognostic markers, it keeps me busy, gets me invited to talks. But for a personal thing, for an individual patient, being positive and negative for a particular marker really doesn't matter. There's one exception, that's P53. All the rest don't matter. So wait a minute, if one on its own doesn't work, what you need is the great and the good, world computing, da-di-da, we can look at big data. And along came the CLL International Prognostic Index. That gets it to 72%. Wow. A real breakthrough. So when you're there with stage A disease, and you're thinking, am I going to be okay 1 year or 20? The information you're given is 2/3 accurate, 70%. You can't base your life decision on that. Or 2/3, no, your disease is going to wake up in the next few years. 1/3 of the time, that's going to be wrong. So although there's a whole industry out there, although a lot of patients worry about it, for you as individuals, with the exception of 17p, they're mostly irrelevant in terms of what happens to you. Some will become more relevant when we come to treatment, but we'll touch on that. So if we have a little look of who with stage A disease is likely to need treating, this is one of the tests we developed in Cardiff called Telomere test. This is 90% accurate. But no one wants to fund it, but never mind. We're spending all the money on treatment. Telomeres are very interesting, they get shorter as we get older, but we're all very different in how long they are from birth. And women's are longer than men. And it's one of the theories why men die earlier than women across the patch. It's not they've nagged you to death. It's your telomeres are shorter, sorry blokes, it's just the way it is. So who does need treating? We have the criteria, and your doctor will go along and say, oh, I think it's waking up, but you haven't reached the threshold yet for needing treating. And again, that seems a bit odd, doesn't it? Well, what, so it's grown a bit, but you still don't want to do anything. There's international criteria why. And the main reason for this is because outside the UK, most healthcare is private healthcare. So hello there, Mrs. Jones. You're feeling tired. Oh, you got diabetes, hypertension, you've had your colon cancer out, your kids are driving you nuts, your son's in prison, rah, rah, rah. No, I think you're tired because it's your CLL. Your lymphocyte count's 6, your stage A0, but I've got some tablets. So basically, commissioners insisted we have criteria, international criteria, who should treat and who shouldn't. Because left to the doctor, I treat everyone. Ka-ching! I'm really wealthy. Hello, darling. Shall we go out tonight? I've treated 6 stage A CLLs. I'm £2,000 better off. Buy yourself a new frock. Your boyfriend says you look good in it. So to standardise care and to get pharma companies to behave better, they had to standardise the criteria for initiating therapy. Again, that's really aimed at the herd, not the individual. And the back to the most difficult patients are those patients who don't fulfill any of those criteria, but they're phenomenally tired. Life is really difficult. They can't manage work, they're not coping at home, and there's consequences of that. And those are the difficult patients in terms of deciding whether to treat or not. And to have that conversation with your healthcare provider, you need to have a very good relationship with them and the information free-flowing. So, the first step for patients, the essential steps, is get the correct information and try and relate it to you. Everyone needs help. There is no shame in telling people, I'm worried about this, I'm worried about that, I'm concerned about this. We're going to talk about infections, and then there's stay healthy. So if you are watching weight, you may or may not need treatment, but over that 10 years, you can let yourself go, carry on drinking, eating, and doing what you've always done, or you can do something about it and get yourself in the most positive state you can in case treatment is ever required. Risk factors for infection, because infection is a big, big problem in CLL. They are endless. I'd like to highlight smoking. I won't ask you to put your hands up if you smoke. I know who you are. 50% of patients who smoke die of a chest infection with CLL, whether or not you've ever had treatment. So when patients come to me and say, what can I do to help me with my illness, doctor? I say, stop smoking. Yeah. Apart from that, what else can I do, doc, to help me? It is the most single thing. Stop smoking, number one. Keep yourself as fit and as healthy as you can. Infections, 10 to 20% have low antibody levels. So some of you will be on intravenous immunoglobulin. But in fact, if you look at CLL, and this is a paper published last year by my colleague Steve Mann in Cardiff, there's over 30 reasons why CLL patients get infections. So when you go and see your GP, they say, I think I've got an infection, and they say, well, I don't think you have, it's probably a virus. The GP doesn't know any of this. You are different to everyone else when it comes to infections and need for antibiotics in so many ways. I'm doing a similar teaching session with GPs next week. I've got 50 of them. I'm going to bend their ears on your behalf. Yeah, that's absolute. Bit more bloody enthusiasm then. Yeah, come on. Come on.
What about the receptionist though?
That'd be a very interesting study. How could you best help CLL patients? Is it A, chemotherapy? Is it B, spend money on a gym? Or is it C, kill off the receptionist? I wonder if it gives more value for money. I can't. I was one of 9 children. When we fell ill, we had to go and see Mrs. Sievers down the road because she was a GP receptionist. She told my mother what was wrong with us. She was bloody good, actually. I mean, I thought she was fabulous. Yeah. Vaccinations, big thing, vaccinations. No live vaccines, absolutely none. No live shingles, no yellow fever. No live vaccines at all. You can get the disease from the vaccine. But in reality, CLL patients do not respond well to vaccines. So the fact you've had them doesn't mean you can't get the infection. Another learning point for GP. So if you take the Pneumovax, the pneumonia one, only 60% respond. 40% don't. It makes absolutely no difference. Your immune system can't respond to it. So you need prophylactic antibiotics. The meningococcal Haemophilus one, it's only 40% response. It's not a reason not to have the vaccine, because you may be one of the lucky ones who do respond. But you cannot assume, because you've had your vaccine, you can't get the infection. And your GP can't assume you can't get the infection because you've had the vaccine. Because in fact, most patients don't respond normally. The immune system in CLL isn't right. But still get vaccinated. More important, get your partner vaccinated. Because unless you actually get creeping into the nurse's room and getting in their bed at 2 in the afternoon, the most likely person you're going to get something off is your partner. Or the grandchildren, or your children. So get your partner vaccinated. It's difficult to insist the newborn grandchild is vaccinated, but you can always try. And your children probably won't get it done. Don't come into contact with anyone with known infections. If you can avoid, you'll get them easier, and you'll get them worse, and you'll be harder to throw off because your immune systems are not normal. There are guidelines about vaccination where we give the Prevalent and the Pneumovax. I'm not very happy with it. The Prevalent vaccine is the one. Prevalent 13, most people get Pneumovax, that's not the right one. Prevalent 13 followed by Pneumovax. The truth of the matter is there's never been a study in CLL patients to whether that works or not. That's based on non-CLL patients, but that's the present recommendation for it. So if you've not had your Pneumovax or your Prevalent or your meningococcal, get away and get your GP to do it for you. And the earlier you get it done in your illness, the more likely you are to respond well. So if there are, stop looking after your grandchildren. Tell your children, sorry, I can't do it today. They've got the snuffles. They've been sent home from school. Who's been called because the grandchildren have been sent home from school because they're not well? Yeah, it's completely bloody illogical, isn't it? You should be the last people. Yeah, if he's taken a knife out and tried stabbing the teacher, maybe, there's no reason you as a CLL patient can't deal with that. But if they've got infections and they're unwell, they shouldn't be ringing you, but that's probably the norm for most people. Is actually because the parents are too busy at work They can't be disturbed. Get grandpa and granny because they've got nothing to do and they can just do it. No. Intervenes and immunoglobulins for those with low antibodies if you get infection. Sorry, sir, carry on. It's a very good question. It's back to that, what do you tell your employer at work about that? Because if you turn around and say, I can't teach children who have the sniffles, you're probably out of a job. Well, you can join the nurse, obviously, the school nurse at 2 o'clock in the afternoon. But it's very, very difficult to get that balance right. Because unfortunately, I have had teachers, primary school teachers, I had one who gave up work. They actually couldn't get through winter with it. They did it for about 3 years, and they said, I just can't do this. I'm off sick all the time. It's not fair to the pupils. It's not fair to the school. And they got themselves another job. It's a drastic thing. But snotty little kids have snotty little habits. And they tend to share their bugs around. It's a really difficult thing. Again, back to you're more likely to get the virus, a viral infection from, have your antibiotics at home, that if you do carry on working, the first sign of anything for you, you're straight on the antibiotics. And your GP needs to understand that. You're back to, you're different. Yeah, if you're sat in an office on your own all day, your risk of infection from someone is nil. Your risk of boredom and alcoholism is probably higher. But if you're a teacher, your risk is high. You're different. You may need antibiotics kept at home just in case, or even keep them at school. You know, if the kids get sniffles at lunchtime, why wait till you get home at 5, 6 o'clock before you start them? You take them there and then at lunchtime.
Excuse me.
Of course.
Is it possible, I don't know if I've asked you this before, is it possible to set up something with the GP that there's a prescription always at hand to pick up if you're a CLL patient?
You have to discuss with your own GP whether they're happy with that sort. Some GPs are very happy, very willing to let you have those sort of. Other things are very reticent because all GPs are being bombarded by government that we use or abuse antibiotics all the time by handing them out unnecessarily. And that'll be true even for some CLL patients if you have got them. They won't all need them necessarily, but having them there just in case. So about having that conversation with the GP about, you know, I am slightly different. I'll be really grateful if this could be arranged, some sort of arrangement like that. Or have them.
Held at the surgery or the local pharmacy.
You've still got to get past the receptionist, haven't you? Yeah.
But personally speaking, if I said to my consultant, would you write to my GP and recommend that they do that, that would lend credence and weight to the GP and they wouldn't refuse.
I do a lot of that, right to the GP. Ever so sorry to remind you, but this patient is, well, I'm sure you fully understand, but maybe your receptionist doesn't, for this patient. Yeah, if in doubt, blame the receptionist. Any receptionists in the audience? No, sorry. Yeah. The way you're dressed in black, I thought you might be. Yeah.
If you ask though for a longer prescription, my husband was here and he had bad infections from September to November last year. It's because we kept going to different doctors and we didn't know they'd give him 5 days of antibiotics or 7 days. And in the end, it was only a 3-week course that stopped it.
So, personally, there's no evidence base. I tend to give 10 to 14 days. But again, GPs are under enormous pressure. You give the minimum 3 days for a UTA, 5 days for a normal infection. It usually is not enough for a CLL patient. But there's no study showing that. There's no study you can quote saying these patients had 5 days for their chest infections and these had 10. But over 32 years, I did my first CLL clinic the 1st of August 1987. I arrived in Cardiff as the first bone marrow transplant fellow in Wales. And they said to me at lunchtime, by the way, you're doing a CLL clinic this afternoon. And I said, what's CLL? He said, don't worry about it. There's only one drug, it's chlorambucil. The nurse will tell you how to give it. Oh, that sounds like an easy clinic. 1st of August 1987. I wasn't even employed to do it, but anyone can look after CLL. So early antibiotics, either in the house or straight to your GP. If you're not sure, ring your GP and break down the receptionist. You know, just don't not take no for an answer.
consultant had released her. And by 12 hours later, she was back in.
Yeah.
And the hematology consultant said, you can't treat CLL the same way you treat anything else.
No, they don't. No. Doctors are not perfect. You got to remember, we always wanted to be vets. We just didn't get the A-level grades. You know, so we couldn't look after more than one animal, so we just decided to specialise. We weren't clever enough to look after more than one animal. So we specialised in one. So yeah, we do vary. Early antibiotics is an absolute must for everyone. Let's talk about treatment. So we've got the illness. We've got a picture in my head of what this needs for me. I've got my coping strategies. I'm watching weight. Hopefully I never need treatment. Of course, for a third of patients, they present with advanced stage disease, they're unwell, they do need treatment early. So here we go, there I am in 1987. We still only had chlorambucil in 87. Fludarabine came in 1992 in clinical trials. Chlorambucil, British drug, GSK, it's a failed chemical warfare agent, is chlorambucil. It is. It's solid nitrogen mustard is what it is. And it's devised as a chemical warfare agent to be dropped out of planes on the enemy. But you need a massive dose of chlorambucil to kill you. And even if it does, it takes 4 weeks. In the height of the Cold War, a Russian soldier could kill an awful lot of you in the 4 weeks. And a lot of chemotherapies actually came from the defence industry. So chlorambucil is a British Army drug, and that's why GSK, Glaxo as it was, took it on, because it's a great British company. Lots of drugs like that. Bendamustine is an Eastern European failed chemical warfare agent. That's where a lot of these drugs come from. Doesn't mean they don't work. 1992, along came for that, and then we're going to go for a few of these newer super-duper non-chemotherapy agents. We're going to take a little whiz through all those to give you a feel for the progress that's been made since I first hit that clinic on the 1st of August 1987. Not that I'm traumatised by it, but it does keep coming back in my nightmares. Therapy is pretty fabulous at the moment. Really, really fabulous. There is no cancer that has more chances of getting a response than CLL. We've gone from the last in 1987, where what we had didn't work, but it's the only thing we had, to where we are now. We're going to go through that, and we've done it without chemotherapy, or we're going to do it without chemotherapy. But let's take one step back about treatments. Where do they come from? We've touched a bit. A lot of them actually come from the defence industries. Those were the people who had the development budget, research and development budgets after the Cold War, after the Second World War. A lot of it came out of that. But developing drugs, most of these companies, they're not trying to find treatments for you. They're trying to find markets. If they can solve an unmet need in the market, then they've got something maybe to sell. We go through various phases of studies. Phase 1, first people ever get it, mostly aimed at does your hair turn green and your arms fall off, is phase 1. I do those sort of studies in Cardiff, always a sleepless night for me, as well as the patient. Phase 2, we think it works, we think it's safe, let's get a bit more data. And phase 3, we're comparing that new drug with the gold standard. Is it actually better? That whole process typically takes about 10 years and costs a drug company about 300 million. And only 1 in 3 drugs, having even gone through phase 3, actually makes a profit. So these drug companies are trying to make £1 billion out of each drug that succeeds, because they have to make up for those failures along the way. So unless they think they can make their money, even effective drugs have been dropped in the past. Patient preference, we'll talk a bit more about that. Commercial company considerations. So, Ibrutinib is going to go off patent in 2025, 2026. So that means the price will plummet, absolutely plummet. So am I going to develop my new drug, which I think works, knowing that when the price of Ibrutinib plummets, I may not be able to make money because I'll have to drop the price of my drug? All these things are going on in global pharma before they actually go forward with the drug. And then, of course, even when it is licensed, it is proven to work, we then have the NICE who do the cost analysis of it, cost benefits analysis side of it. But let's just go back a second and talk about the 4 therapies which make up the mainstay of things. Chemotherapy, cancer cells grow quicker than normal. True or false? It's false. Absolutely not true at all. Cancer cells do not grow quicker. 1 cell divided becoming 2, 2 divided becoming 4, 4 divided becoming 8. That is not correct. They do not grow quicker than normal cells. Chemotherapy stops the cells dividing. They bind the DNA. Bit of a biology lesson. You've got 46 chromosomes in a cell. If that cell's going to divide, you need 92 chromosomes. 46 times 2. Then the cell divides, 1 makes 2, gives them 46 each. Yep? Chemotherapy binds that DNA so it can't divide and make a cell. That's how chemotherapy works. Monoclonal antibodies stick on the outside of the cell and give a lethal injection. They don't touch DNA. That's why they tend to be less toxic. We now know how CLL cells stay alive. Everyone concentrates on the white blood count, but the action, the real action, is occurring in the lymph nodes, even if you haven't got big lymph nodes. That's where the cells are accumulating and then being released into the blood. And what they do, if they float around the blood, and if they're getting a bit tired, they then have to go back to the lymph node and refuel. So it's like your car. Hands up, you got a Tesla? Yeah, you bloody lot. Yeah, you're destroying the planet for the next generation. You lot. If they don't get back to the lymph node to refuel, they die in the blood. Ibrutinib and those protein tyrosine kinase inhibitors stop them going back to the lymph node to refuel. So they hang around forever, take up to a year, your white count can go up with Ibrutinib, and they die in the blood. So the lymph nodes usually shrink very quickly because they come out of the lymph node, but they can't get back in. And then eventually die in the blood. Nothing to do with chemotherapy. So, when I say they don't grow quicker, cancer cells, what do they do? Let me ask you a daft question. They don't die. Why does your hair keep growing and your nose doesn't? On some people it does, but we won't go there. It's because you eventually reach a point on your nose, it stays the same size, means if 1 cell dies, it's replaced by 1. And all cells in the body have a finite life. What cancer does is stop them dying, so they accumulate. And that's why chemotherapy doesn't work for the overwhelming majority of cancers, lung cancer, stomach cancer, bowel cancer, because they're not growing old. The little bastards are just not dying. They refuse to get off the dance floor. It's the drunken uncle at your daughter's wedding. He just refuses to go. These things do not die. The thing that keeps them alive is the BCL2 family of proteins. And Venetoclax is a BCL2 inhibitor. So those cells that should have died are invited to die by BCL2 and Venetoclax. It's not a chemotherapy. We have all those now to put together. So if one treatment doesn't work, what you tend to do in the past is put them together. We had chlorambucil, equivalent to cyclophosphamide, you add it to fludarabine, you add it to rituximab, giving you FCR, which is the standard treatment for the, quote, fit and young. I've seen some wrecks of 45-year-olds, I tell you. And I've seen some amazingly fit 80-year-olds. If you've got mutated IGVH FCR treatment, 80% are alive and well and probably cured at 10 years with FCR. A third of patients have mutated VH. That's when those prognostic markers matter when deciding which treatment you're going to get. But who's had fludarabine, cyclophosphamide, rituximab in the room? Yeah. A walk in the park, was it? No, it bloody wasn't. It's not nice. It is not nice treatment, and some people come unstuck with it. if you don't come unstuck and you get through it okay, and you've got mutated VH genes, you may well be cured as individuals. We need longer follow-up, but you may well be cured. So everyone says, I don't want chemotherapy, but for a subgroup of patients, it may be your best chance of cure. But the new boys are coming along. So here's Ibrutinib. It's not a chemotherapy. It stops those cells getting back to the lymph node to refuel. So first of all, the side effects are very, very different to chemotherapy. Really very different. A lot milder. About 15% of patients get more serious side effects, that's in more severe, not serious. But if you actually look at the survival curve, it's quite amazing. So this is the original data from this. If you just look at overall survival, unfortunately I haven't got a pointer. Who have I? Have I got a pointer? I may have. Oh, wait a minute. Oh, so you look here, these patients on Ibrutinib, overall survival, 90% have got to 54 months and are well, and the disease hasn't done anything. So we're now out to 8 years, 7-8 years with these. These can't be cured because the CLL is still there. We can still detect it, but the patient is alive and well and getting on with their lives with a tablet, literally every day, which is not a chemotherapy. So if you're one of the 85% who don't really get serious side effects from it, it's potentially going to keep you going for a very, very, very long time. So Ibrutinib was a game changer. But wait a minute, maybe we can do better with Ibrutinib with rituximab. Maybe Ibrutinib with rituximab can be as good as FCR. Here's the original data showing that Ibrutinib rituximab, literally 3 years, is better than FCR. Non-chemotherapy, relatively non-toxic, is better than FCR in patients. But we're not going to see IR licensed by the company. They're not going to bother by all likelihood. Fabulous, but it does tell us that these non-chemotherapies can be better than chemotherapy. Side effect profile, surprise, surprise, a lot less with Ibrutinib than anything else. So wait a minute, what about other treatments? Bendamustine rituximab, similar to FCR. Maybe for patients less fit, FCR, you've got to be pretty fit and healthy to be considered for it. Bendamustine rituximab is what traditionally been used for the less fit. Compare that with Ibrutinib rituximab and Ibrutinib alone. I'm going to slip through. If you look here, there's bendamustine rituximab. There's Ibrutinib on its own and Ibrutinib with rituximab. You get no advantage by adding rituximab to Ibrutinib. Hands up if you're in the FLAIR study. Hands up if you've got Ibrutinib rituximab. Hands up if you've got Ibrutinib on its own. Yeah, see, this data would suggest that in FLAIR, maybe the IR arm won't do any different to the eye. But that's good, it's easier for patients, cheaper for everyone. So that's the first study showing Ibrutinib alone, this and the other one is better than chemotherapy. Side effect profile, again, Ibrutinib much better. Works for all grades of patients, and the side effect profile, significantly less patients run into trouble. Wonderful. We can go further. What about those more mature patients for whom chlorambucil obinutuzumab is right and that they can't tolerate a fludarabine or bendamustine-based regimen? So here we go, chlorambucil obinutuzumab, standard treatment, versus our friend Ibrutinib. All patients, there's Ibrutinib. Much better than chemotherapy and monoclonal antibodies. So what the message is, we're seeing less toxicity, all groups of patients, all those subgroups, all those prognostic marker people did better with Ibrutinib. We still haven't got it yet for upfront patients. But we have another drug we talked about, as I said, Venetoclax, that BCL2 inhibitor. How does that compare with chlorambucil and obinutuzumab? This is a CLL 14 study. Here is the data. There's Clamacillin obinutuzumab. There's Venetoclax obinutuzumab. Significantly better. So ironically, Ibrutinib, despite we've got a lot of data showing it's better than chemotherapy, it's probably not going to be licensed for upfront therapy in the UK. And that's probably because, well, I know why. There's competition coming along and the patent runs out in 2025. But Venetoclax obinutuzumab is going through NICE now. The great thing with Venetoclax, I say it's not a chemotherapy, is actually a much higher response rate, complete response, than you do with chemotherapy. Toxicity, ironically, although it's not a chemotherapy, the toxicity is similar to a chemotherapy. Whereas Ibrutinib is a lot less. With Venetoclax, it is a more potent drug at killing cells. Toxicity, very similar in reality. In relapse, bendamustine rituximab, if you've had previous treatment, Venetoclax rituximab, you'd be better with Venetoclax rituximab. So we've got data, these new agents are better up front, and they're better in relapse. In relapse, we can use Venetoclax rituximab for anyone. We use Ibrutinib in relapse. I didn't bother showing you that data. And the new kid on the block coming along, which is also going to NICE, is a thing called acalabrutinib, cousin of Ibrutinib, which they're looking to license for both upfront and relapse refractory. And that's with NICE at the moment. So potentially by the end of this year, we'll have Venetoclax obinutuzumab up front, acalabrutinib obinutuzumab up front, and Ibrutinib, Venetoclax, acalabrutinib for relapse. Chemotherapy will drop off the therapy regimen. That doesn't mean it can't work and it couldn't do a job for individuals, but it looks like we have better things we can use earlier for patients. And that's especially important because to say fludarabine cyclophosphamide is no nonsense. So these sort of treatments we can give to a lot more patients than maybe we could in the past. Toxicity, very similar, but all groups did better with Venetoclax, every single one. The thing with Venetoclax is minimal residual disease. How much disease have you got? We can now detect one CLL cell in 10,000 normal cells. That's our level of detection we can do in the lab. And what you're seeing is in a high proportion of patients that actually we can't find any sign of the disease at 18 months. It's a 2-year therapy, Venetoclax. It's more potent than any chemotherapy we have ever had. Going forward, we've had Ibrutinib first. So Ibrutinib fails for whatever reason, be that you're one of the unlucky ones with toxicity, side effects, or maybe just stops working. Wait a minute, you can give those patients Venetoclax afterwards and actually do very well. There's the overall survival. So you've failed Ibrutinib, you go on to this, it works really well. But wait a minute, why don't you give the two together? Why do one after the other, or vice versa? Why not give them together? This is a Clarity study, which is the British study. We took part in it in Cardiff. In fact, there's somebody in the room I know was in Clarity. Here, you get 8 weeks of Ibrutinib, and then you get Venetoclax. So there's no chemotherapy. And this study was for patients who previously failed other therapies, not people up front. Move on from that. What it shows again, you get a high rate of no detectable disease. We can't say that's cure, but we can't find it. 1 CLL cell in 10,000 normal cells. If you look at the regimen, everyone, after 8 weeks, so after 4 months, 8 weeks of Venetoclax, 16 weeks of Ibrutinib, has a normal blood count. It's phenomenally potent stuff. Here's this level. 1, that's your white count of 1. Everyone was below white count of 1. within that period, and most people, you can just about detect it by doing the fanciest of tests. You can't call that cure, but FCR, super duper chemo, didn't get anywhere near that number of patients down to that level of disease. So down the line, it may be we combine the two, but at the moment we're not in a position to do that. But the data suggests Venetoclax is the best drug we've ever had, and combine it with Ibrutinib may be absolutely amazing. We see complete responses, even those patients who failed FCR, even those patients who've had prior novel therapy with idelalisib, they respond phenomenally well. So we're about to move into probably the first cancer, common cancer, where chemotherapy is not the mainstay. We have other things to treat it with. Venetoclax, in fact, is being tried in all sorts of cancers. Lung cancer, colon cancer, myeloma, you name it. Because that problem of the cells not dying is true of all cancers. So it's actually being tried elsewhere, all over the place. I haven't got shares, unfortunately. They're too expensive now. If I'd known all those years ago what I know now. The more you understand about you and your CLL, the more you've thought about it, the more you've asked, the more you can push this thing to the margins of your life. That is the clue, the key to successfully living with this disease. So you live 20 years, but that's no good in that if you don't leave the house. You can't go and see the grandkids. You can't eat the sort of foods you want. Getting that balance right and being positive and putting it where it needs to be for you is phenomenally important. You can then take control of it, not it controlling you. This is the Doctor Who generation. We're all brought up with it. You know, that no one controls the Doctor. Even the new one. You need to be like Doctor Who. You're always in control. If not at the beginning of the programme, certainly by the end. Alas, we often deny it, but doctors are human. We do have bad days. We're not our best. We do have bad moments. The wife rang me up to say, can I pick the kids up from school? I said, don't be stupid, you know. And on occasions, maybe you do need to challenge them. And the reason is simply that you will leave that room feeling really quite unhappy with things. You need to leave any consultation feeling that you've got something out of it. As I say, we have bad days at work. Do challenge them. Yeah, it's got to be challenged for the right reasons, for the right things. But that consultation is, yeah, okay, Mr. Jones, everything's fine, your blood count's fine, no nude nose, see you in 6 months. For some patients, that's enough. For others, they've got unresolved issues from the past. Well, what about this, doc, and what about that? Because those are the things that are making you think about your CLL every week. Yes, it's reassuring to be told there's nothing happened, but your white count's gone from 10 to 12. The doctor says, don't worry about it. If your white count went from 10 to 12, who would worry? 10 to 20, who would worry? Yeah. One of the common things we have is GPs ring us up saying, I've just seen Mr. So-and-so, his CLL's progressed. Really, yeah, white count's gone from 14 to 25. Oh, really? Yeah, fine. So can you see him urgently? I've told him to come up and see you. The patient comes and says, so why do you go and see your GP? I've had this dreadful water infection. Your white count's meant to go up when you get infection. That's your body reacting normally. You treat the infection, the white count goes back from whence it came. You only see your bloody GP when you're unwell. Of course your white count goes up. But that's the commonest reason why we're phoned by GPs is the white count's gone up. They don't understand that actually that's normal. You're worrying more because you're thinking, I wonder if that my disease has progressed. And they say, don't worry, I'll ring the hospital to see you urgently. That's really bloody reassuring, isn't it? The GP's hardly going to ring the hospital if he thinks it's nothing. And usually I see the patient, you treat the infection, I say, yeah, I'm sure it's nothing. I'll see you in a fortnight when you got over the infection. And 9 times out of 10, it's gone back to normal. 1 time out of 10, I'm wrong, the disease has progressed. There's no way of knowing that 2 weeks earlier, because we've got a reason why your white count went up. So do not be alarmed if your white count goes up. It's the least important thing. It's the thing which everyone goes with. Hands up if you like walking out with your blood count form, with the results. Yeah. And you've got them stashed away, and you look at them, and you get them out at night, and you have a look again, and you try and say, well, how come it's 25 last time and now it's 23? Does that mean my leukemia is going away? Of course it doesn't. Having a result is great, providing you use it as a positive tool. It shows nothing's happening to me, and it shows that when I'm going to work tomorrow, I'm fighting fit, I'm going to give them a piece of my own bloody mind. Not that, oh my God, my disease is progressing. I wonder if I'm up to the argument tomorrow. Yeah, get on with your life and try and put it behind you. Prognostics are of limited value, but we spend a lot of time on them. We are truly moving into curing patients. The most incurable disease when I started haematology is going to be cured. Some of you in this room may already be cured. I won't ask you to put your hand up, because I don't know who you are. I could bet the wife's half of the house who you are, because I know what treatment you've had and I know a bit about you. But some of you are going to be cured. An awful lot more of you are going to be cured in the sense you're going to have a normal life expectancy. Do not leave your money to the kids. People don't appreciate what's given them. If you earn it, you appreciate it. Anyway, you're going to live 25 years. You need it yourself. It's for you. It's not for them. They've already bled you dry emotionally, physically, and then they want to do it financially. Sod 'em. Get out, enjoy yourself, try not to give too much to the travel insurer, and get on with your lives. Number 1, can you have alcohol if you're on chemotherapy or treatment? There's no evidence you can't. In moderation, yeah. We don't want you falling over and knocking your head when your platelet count's 10. That's not good. We don't want you in the pub with all your mates when your neutrophils are 0. Of course you can. Life's for living. It's not longevity. It's not quantity with life. It's bloody quality. You have the power. You have the knowledge. You happen to be in a time when we have the treatments to do better than anyone's done before. The wonderful thing about my job is the patients. It is truly, truly humbling seeing how people get through life with what's happening to them. I am truly, truly, I'll be bloody hopeless. I'll be an absolutely hopeless patient. I'd look at that doctor and think, you know, sod all about anything. I once had an operation and the GP said to me, do you know so-and-so, so-and-so, the surgeon? I said, yeah. He says, oh, you really know him? I said, yeah. He said, make sure you're on the Monday list. So, yeah. Because he went out every Wednesday night and you didn't want to be on the Thursday list. I wish you all the very, very best for the future. I want to thank you all for coming today, putting all your effort into actually doing something positive about your illness. I'd especially like to thank the CLLSA, obviously Leukemia Care and Lymphoma Association, who've come along to support us all today with trying to move this on. Yeah, the treatments are better, but that's only a tiny bit about actually managing CLL. You're doing the majority of it. I take my hat off to all of you and have a safe journey home, assuming you can get out of Cardiff in the rush hour. Cheers, everyone.